Okay. Um, good afternoon. I hope everybody is staying safe and healthy during quarantine right now. And I wanted to thank everybody for joining today. My name again is Tanya Finan. I'm the VP of Education for the HIMSS Arizona chapter. And as all of us have been living through the current COVID-19 pandemic, we've been working to get some webinars scheduled and bringing valuable information to our members. So today, joining us is Lucy Parente with Optum, who works on the Payer Provider Solutions team, and she's going to be talking about the current and emerging COVID-19 landscape. So before I turn it over to her, I'd like to say if you have any questions during the presentation, please feel free to write them in the chat box and we will get to those towards the end of the presentation. And in addition, this will be recorded and available for future listening. So Lucy, I'm going to go ahead and turn it over to you.
Great. Thank you so much, Tanya. This is Lucy Parente here speaking. As Tanya mentioned, I am from Optum. I work on the Payer and Provider Solutions team, so really closely partner with our provider and payer clients to really understand how our analytic solutions, so our analytic population health focused solutions, can really provide value to them across a population health strategy, and more recently focused on responding to COVID-19 and managing really future risk and response to the ever-changing landscape really that we're in right now. And I'm calling in from Boston, Massachusetts, so I'm really honored to be able to speak today and really access perspectives from across the country. Optum, a quick highlight around really what Optum does. We're a health services innovation company, and our presence exists in multiple markets spanning the healthcare space. And I really focus on, as I mentioned, payer and provider support, really understanding the challenges that they have while being able to call upon our expertise and best practices in other markets, including government and life sciences. And broader Optum focuses on several different facets of the COVID-19 crisis and really issues that all of us are facing today. So partnering with organizations in that life sciences branch and division to drive support from an immunization standpoint and clinical trial perspective, amongst others. Really what I'm planning to focus on today for our presentation is building an analytic strategy around population health. And we've been, as everyone I'm sure on the phone today we've been responding really as quickly as possible. So the crisis and the COVID-19 landscape has been incredibly complex, changes on a daily basis. And in the last several weeks, we've had to think through what are the opportunities and areas where we can support our clients today, while also thinking through the landscape is really here to stay and the complexities will continue to grow. So in the next several months into years, how can we continue to think through providing top-line care to patients and really taking care of our providers and hospitals? So I'll start with a top line of the landscape, really as it is a means to getting started with a strategy. So where are you potentially in your surge, and how can that then inform what your immediate priorities might be and your long-term priorities? I'll spend the bulk of the time going into some actionable opportunities. Really, we've been working in real time with our clients to understand what have they already done and where can we meet them halfway, how can we support them where they are, and really what can we do to also challenge them to think forward. And I'll close with some of those notes around emerging areas and future considerations. There are so many factors that continue to be added to this complex equation that is a response to COVID-19. So what are some additional items that should be part of the population health strategy as we gather additional data and information to those effects? So getting started here, this framework will be present throughout the presentation and really is how my team has been thinking about that analytics strategy for population health. And it's really resonated with a lot of our clients. And it's really resonated with a lot of our clients around preparation and prevention as leading up to your potential surge, mitigation and management, and delivering care responding to cases of COVID-19, and assessment, being that post-surge, really understanding as we collect data and as we really think about analytics is the analysis of all of that great data we're able to capture. How can we use that to more appropriately and effectively prepare for potential resurgence? In terms of the COVID-19 landscape, this is how those three phases really come into the crisis that we've been dealing with. Starting in January, February timeframe, we were really challenged to respond quickly. And the crisis response is that phase that most of us and most of the healthcare organizations are in right now. And that is really starting in the mitigation and management phase. There was not a ton of time for preparation. Some of the mid of the country states did have a little bit more of an opportunity to prepare and think through a response strategy as their surge dates, estimated surge dates, were a little bit later into May. Easing social restrictions, this has been top of mind, especially recently, I would say over the last week or so. How do we ease social restrictions and start opening some businesses, start having folks go back to work, and really think about, from a healthcare perspective, starting to schedule those elective surgeries and really dealing with that pent-up demand as folks were staying home during the outbreak and during the initial crisis response. In that phase, from a social perspective, we're going to ease the restrictions and really take lead from federal and state governments on how to do that appropriately and when we can do it. But what that means for healthcare organizations is the focus on assessment. All of the data we have collected during the crisis response phase is going to be critical as we prepare for potential mini surges and a resurgence. So if in the fall or winter timeframe we are expecting a potential surge again, how can we be better positioned? And that puts us into preparation and prevention. So really over the summer, what can we be doing to set us up for success in delivering top-line care and taking care of our hospitals in the fall and winter and ongoing? This is a short-term look ahead. However, we will be dealing with this type of cycle, I think, for the foreseeable future. So getting now into creating a strategy, I'll dive into each of those three phases in more detail and start to talk about what are we hearing in the market, what are we hearing from clients, what are some great examples of things that organizations are doing in each of these phases, depending on where they are right now in their surge. So preparation and prevention. The goals here are, as everyone is aware of, increase capacity and determine where I might need to surge or expand, reduce unnecessary use of limited resources. So PPE really counts there, as well as providers and your actual staff. Reduce the spread of infection and exposure of high-risk populations. This is a huge goal and will be another primary goal as we think about mini surges and a resurgence in the fall. How do I ensure the number of cases can be actually managed by my healthcare organization? And now I'll detail out some of those specific use cases. And if anything, I think this presentation could be a starting point for a playbook of organizations thinking through what are my opportunities, where do I need to focus? So these are some of those specific opportunities now. From a preparation perspective, One of the key use cases that our clients have really been focusing on, and across the country, this is a focus for organizations that deliver healthcare, identify the high-risk populations. It sounds somewhat simple, just identify who those people are, but it's critical to really understanding what can be my proactive outreach strategies. So I'll detail out on the next slide really who are the high-risk patients and how can we do that. But ultimately, this goal is to keep patients out of the hospital if you can, really help them manage their symptoms if they develop symptoms from home or from a different care setting that increases capacity for us in our hospitals. Of course, reducing exposure in the first place would be really important. We want to make sure that those populations stay safe and stay healthy. Identify the vulnerable populations. So this is a little bit of a different lens to that use case. Vulnerable being, we're starting to see some evidence and data indicating that certain races or socioeconomic or cities that are maybe poorer in sort of distribution of their population are really trending towards higher risk. So how can we identify who those people are and how they interact with my healthcare system to understand the opportunity to interact with them and deliver them care in a unique way that really meets them where they are and really responds to the types of resources they might have access to versus those that they might not. Analyze historical inpatient and ICU capacity. This is identify that baseline of my historical utilization in the hospital to help me prepare for resourcing and also creating that capacity that I might need in advance of a surge. We didn't have a lot of time to do this the first time around, but the more we can look retrospectively at inpatient data, ICU information, ventilator use, all of that to help inform how we can create resources across our system and also invest in new resources or redistribution of our staff as appropriate. Predict future utilization over time. Predictive models have been such a hot topic within analytics, especially the payer and provider spaces. How do I understand when I'm expected to surge, what's going to be the total number of inpatient or ICU beds that I will need, ventilators that I will need? All of that has been such a hot topic. And of course, development of risk scores really relies on a significant amount of historical data to effectively create and train a new risk model. That said, there are several out there in the industry, in the market, that are giving provider organizations that visibility. And that's been helpful to help them trend towards an expected surge date and think about resourcing effectively. Identify and prioritize delayed elective procedures. So this is, as I mentioned over the last few days, really starting to surface up as what provider organizations need to think about next. How can I identify really what is the volume of elective procedures and surgeries that were canceled or delayed during the crisis response? What does that volume look like? What are the expected average lengths of stay associated with some of those? And where do I start in terms of scheduling? So how do I prioritize? Should I prioritize based on severity? So clinical severity has been a key driver of helping to prioritize through the huge backlog that some organizations are working through. Once we get through really clinical severity and urgency, strategic importance really does play a role. So that might be the margin per case or competitive advantage to opening up earlier and scheduling some of those. And then feasibility. So being able to schedule those elective procedures is dependent upon the number of tests that you have access to and PPE and providers, surgeons, and anesthesiologists, and that ability to actually schedule those procedures. Analyze retrospective utilization for diagnostic chronic population management. This is another lens on that pent-up demand. So the elective procedures and surgeries is expected to have to be rescheduled and brought back into your network. But what's also a priority is understanding the population of which those patients have chronic conditions and they decided to forego care during the crisis response. So they actually stayed home. However, the cancer patients, the diabetic patients, the heart failure patients all still exist. So where are they being managed and where are they in their disease progression? So how can we look at historical data, specifically for really small windows of time, so maybe end of February to early March of the prior year, to help inform what was expected for this year and how can we identify the patients that should be, brought into proactive specialty care. So there's remote specialty care that a lot of organizations are focused on and investing in now. And those patients that do need to still be seen in person and need to be going in for their labs on a regular standard cadence. A case example here is that first use case that I presented around the high-risk model, a high-risk population for proactive outreach and severity mitigation. So identifying the population I mentioned is fairly straightforward. And here's an example of using a CDC-based, evidence-based cohort using the CDC guidelines. So those were changing really on a daily basis for a bit of time. But what's been consistent is the over 65 population or patients with COPD, asthma, diabetes, and heart conditions really are considered to be at highest risk for a severe outcome if they were to be infected. Beyond that, as you can see here with example data, that's over 100,000 patients that meet that initial definition. So from there, how can you stratify that population to be really a manageable, feasible population for proactive outreach? Additional at-risk factors that the CDC and other regulatory organizations have really highlighted are smoking status, additional conditions like cancer, immunodeficiencies, autoimmune diseases, even stage 5 kidney disease. Some of those can help turn the dial on which patients are maybe at highest risk across this cohort. Of course, being able to also slice that by region, so by zip code or city, even state if you are a national organization, and saying where can I invest based on these hotspots for high-risk populations. And social determinants, that is across the healthcare space, an area of focus that has existed even prior to COVID-19, but is critical in the management of a proactive outreach workflow. Identifying patients that are high risk, but also have unstable housing or are homeless, really is going to change the mechanism by which you outreach and potentially work with that patient to manage their exposure risk than if it's just a patient that can easily socially isolate and can manage their care from home. Some of the workflow at the second half of this slide, once you identify that patient list and you implement some stratification, we have clients that are sending a list to PCPs with the list of patients that are considered to be high risk. These patients have been identified. Should we enroll them in a care management workflow? And what types of proactive outreach can we think through being most appropriate based on what you as their PCP know about the patient and their ability to care for themselves and their risk here. From a proactive outreach standpoint, we've seen clients scheduling automated phone calls to patients, indicating the resources that they have available and the means by which to connect with their providers and their healthcare system. And telehealth more broadly has been one of the greatest topics covered within the COVID-19 crisis response and opportunities here. And so prevention and education are key for managing this type of a population via telemedicine. Remote monitoring has also been something that a lot of organizations have already invested in. Very low-tech remote monitoring sort of devices like thermometers and blood pressure readings can give providers within the hospital that insight into what's happening with these patients and quickly and easily identify the escalation of symptoms to then bring a patient into the hospital, into the actual inpatient setting. Mitigation and management. So the second phase here that we are really, I see most of the organizations in today, and there are several clients that we work with that are really in the trenches of managing operations and really understanding the resources that they have. And what we can think about from an analytics perspective is, yes, understanding the resources that you have, but thinking more strategically about where do we have opportunities? How can I look at it from a macro level to say, this is how I can increase capacity, this is how I can reduce readmissions to, ultimately increase capacity, and this is how I can ensure positive outcomes across my care continuum by delivering this standard of care within our healthcare organization. Some of the use cases here that we've started to think through with our clients, and this list will continue to grow as we learn from the industry and as we learn from any of the organizations that we've partnered with already. Identifying the symptomatic population. So this, for a very short window of time, will be useful in truly managing and mitigation of patients going into the hospital who can be managed at home. So identifying patients with ICD-10 code evidence, really here we've started with fever, cough, shortness of breath as the primary symptoms that across organizations are thinking is the standard for an indicator. Once we identify patients with those symptoms, what types of workflows are most appropriate? So layering in this population with the at-risk population would then also help you understand prioritization and effectively triaging patients to either home health and managing their care at home via telemedicine, or also escalating them to maybe a virtual ICU and having virtual rounds if they need to be managed a little bit more closely, or actually admitting them to the hospital, having them go to a remote testing facility, and really managing them in person. Confirmed cases of COVID-19. So once you've actually been able to capture this evidence and the new ICD-10 code for COVID-19 that went into effect April 1st is already starting to appear in our data in high volumes, and we're really capturing that for our clients so they have true visibility into the number of cases that they're managing per day, the number of tests they're administering per day, and we can really start to track outcomes. So once we've identified the COVID-19 population, what medications are those patients on? What conditions do those patients really have? And how are they being managed? Are they being managed via telemedicine, or are we primarily managing them in the inpatient setting? Drug outcomes. So I just mentioned we can easily track the medications the COVID-19 population is currently being administered, but there are very specific medications that we're all hearing about are relevant in the equation so far, and that I'm sure will continue to change, and we will continue to have factors added to this equation. But how can we isolate the population receiving hydroxychloroquine or chloroquine or interferon or remdesivir? How can we identify those and ensure that they are not intended to treat lupus or RA or malaria or some of those original conditions? This ultimately, in my opinion, is getting us closer to any type of research or outcomes trending we can do based on the data that we have today, knowing that we're all really running before we decided to walk. So how can we observe the outcomes for those drugs within our individual population. Identify discharge patients and ensure that effective follow-up care. So within the hospital and you have your management of COVID-19 patients and you're discharging them from the hospital, how are you triaging that and discharging those patients? And what's the next step? Knowing that there's some evidence to suggest that within a 5-day discharge window, patients may start to worsen and have to be readmitted. How can we prevent that? How can we manage incredibly closely those patients that have been discharged to reduce that readmission risk and to ensure that they understand how they should be managing their symptoms or managing their follow-up care from home or from the post-acute care setting? Identify patients for non-COVID-19 related healthcare. This is, of course, as I mentioned earlier, a priority, as in your chronic population still exists and they are still managing the symptoms or managing the conditions, that they've presented with prior to COVID-19. How can you still deliver effective specialty care? And who are the patients that really need that specialty care? And how can you connect your resources with that population? A second case here is really focusing on that discharge work list opportunity. Drilling into a 5-day period, and that flexibility can really depend on what you're seeing within your population. Does that need to be expanded? Do we need to ensure that patients that have been discharged in the last week are still following some of our post-acute care workflow? But once you identify that discharge list, those patients who have been recently discharged, and you stratify based on the workflow or the programs that you have in place to identify that appropriate population for really the provider to then determine enrollment in those programs, trigger the post-acute care triage workflow. We are seeing in some organizations now that there are specific care coordinators associated with the discharge workflow and the discharge case management. And there are very specific tasks associated with how they interact with those patients and how they determine when their care might need to be escalated to the PCP or the patient might need to come into the hospital and indeed be readmitted. The virtual ICU I mentioned earlier, that's some incredible work that some organizations are already doing. And there's several floors to this virtual ICU to allow patients who have been discharged from the hospital to still interact in more intense care than just remote monitoring or just management by the PCP when the patient needs it, but really ensuring there is that structure to the discharge and you're identifying any type of decline as early as possible. Moving into that third phase, so assessment, and this could be post-surge and could be as you're moving through your expected surge date of cases and volume within the hospital, but it really is also appropriate to think about the post-surge and assessment opportunities throughout this entire life cycle and landscape of COVID-19. Analytics is all about analysis and taking the data that we have access to find opportunities and really make changes for the better within healthcare. Increasing capacity, reducing the unnecessary use of your already limited resources, reduce the spread of infection, again, ensure positive outcomes across the care continuum, not just for your COVID-19 patients, and increase efficiency and efficacy of your technology and workflows. So really quickly, organizations had to think about what technology maybe they already had. How do I use my EMR? But maybe it's the opportunity now for us to develop new workflows or invest in new technology, develop applications that our patients can interact with So organizations are revisiting that technology strategy and how can they support providers and employees via those technology platforms as well. Analyze cost and utilization impact. So revenue is something that maybe folks on the phone are wondering how I haven't dug into that quite yet. Really understanding the impact to hospitals right now based on the lack of revenue from elective procedures and surgeries and some of that ambulatory care that has been foregone in comparison to the revenue that maybe is being captured from treating and managing COVID-19 cases. We're really seeing the numbers right now that indicate it is not a balance and that there is a significant revenue deficit right now based on the loss of a lot of that elective care. So how can you understand your organization's financial health status really across your network and within your hospitals to inform resource and budget planning and the allocation of services? So really early on, it seemed that healthcare organizations were deciding to furlough certain staff members or reassign them to different departments, but really with the goal being to keep hospitals and healthcare organizations whole coming out of this initial surge and preparing for future resurges. How can we really understand the opportunities that we have to increase our revenue, bring patients into our network, and ensure that they have relationships with their PCPs to respond and bounce back from really the revenue deficits that a lot of organizations are in right now? And so from an analytics perspective, what you're going to need to do is understand where you are and really look at the total cost of care for treating and managing a COVID-19 patient and ultimately that population. And also what was the estimated revenue lost. So looking at historical data for those elective procedures to understand the cost for actually having those procedures and really what ultimately did that do to impact your revenue at this point in time. Analyze outcomes across the symptomatic and confirmed COVID-19 population. This is what did we learn and how can that inform best practices for managing patients in the future? So really that is looking across how you were treating those patients. So those with symptoms that maybe didn't have a test or weren't considered to be high risk, and those that were coded with confirmed COVID-19. How were they managed and where were they managed? Did it make a difference to manage patients from their home via telemedicine? Or really within the inpatient population, what were the outcomes? Where were they discharged to? Did they have post-acute care? And to what effect did they have that care? And what conditions maybe did they have? There's of course evidence starting to be present in the industry around conditions emerging from COVID-19. So how can we understand not just the respiratory implications, but also cardiovascular and other implications for chronic disease management? Of course, mental health as well. Mental health and behavioral health across this entire continuum are relevant in the management of your population and the assessment here. How do we understand the % of our population that had COVID-19 or was socially isolated that now have anxiety and depression? And how does that help us also think about strategically delivering technology and support to our patient populations to improve their outcomes across their conditions? Identify potential trends. So within the COVID-19 population, we have the ability to, once we're collecting data and bringing it together to tell a story about that patient that had COVID-19, we can look at geographic, demographic, and clinical and other trends to help us extract any information that will better prepare us for the fall and winter months. So where were the hotspots? Does that make sense? Do we know why those were potential hotspots? Demographically, were there any trends in certain types of populations? And do we have specific support programs that we can target to those populations and meet them where they are in terms of the resources they have. And from a clinical standpoint, I mentioned this in the use case just above, but how can we think about managing the whole patient? Whole patient care has been such a focus in healthcare for several months prior to COVID-19. How can we manage their COVID-19 effects also with their chronic disease comorbidities, mental health, behavioral health, and other factors so that the care we're delivering really is going to be most effective? Analyze the outcomes of patients managed via specific programs. Care management programs and the impact analysis associated with those has been really a priority across the market incredibly in advance of COVID-19. So how can we also apply that here and understand the efficacy of our telemedicine efforts, our care management programs, any specific new initiatives that were implemented for COVID-19 to really position us and modify and deploy improvements for best care delivery, optimal care delivery with future surges. Even as we think about beyond COVID-19, how will this analysis and this assessment of our response here position us in the best possible way for responses to future crises or future outbreaks, as needed? This is the opportunity for organizations coming out of the crisis management phase to understand how they responded and to potentially pivot and really learn from others in the industry and others in the market. Looking forward, so beyond some of those initial areas, and as I mentioned, those will continue to grow, and we are hearing new opportunities and new areas of focus every day. And I would look forward to anyone on the phone if there are others that they want to speak about after the presentation. But there are some emerging areas that, depending on where the organization is today, what resources they might have, and then also the nature of life sciences pipelines and all of that, we have to consider as part of the population health response and strategy. And so those should be layered into the analytic framework really as more data is available to us. And bringing back this timeline, just as we close and think about the response and next steps, moving into the summer months and being able to ease social restrictions, there's a lot of kind of controversy around this. Just, are we ready? Do we have enough tests? Do we have enough PPE? Are we prepared for potential mini surges across certain states and certain hotspot areas? That's still to be seen. However, I think regardless of if this happens starting in June or if it happens a little bit further along, the assessment period can start now. And we are working with some organizations that are national organizations that can start to look at the hotspots and the care delivery they have in those hotspots. And the ability for organizations to pivot and redevelop some of the care management programs is going to be incredible as we move through the next few months. That preparation is ultimately going to set them up for success in the fall. And hopefully by then, some of the ongoing areas of focus here will potentially be a little bit more clear and part of the equation and response when we go back into mitigation and management. Some of those areas of focus, just as I thought about really how else can provider and payer and other organizations that are in the healthcare delivery equation think about the COVID-19 landscape. NLP, AI, and machine learning techniques. So these are all, top of mind, I would assume, for a lot of us on the phone. And within analytics specifically, thinking about providing those really complex, advanced capabilities quickly has been a challenge, but it's something that will be so incredibly worth it if we can move those along really effectively and quickly. So natural language processing specifically for that item, there was that time period between, let's say, December and April 1st, where the coding of COVID-19 cases was a little bit unclear before the new ICD-10 code went into effect on April 1st. You know, how were provider organizations really effectively documenting which patients had COVID-19? So how can we go back and mine some of the clinical notes data to capture evidence of COVID-19 or coronavirus or symptoms in the notes to really give us that effective picture in the assessment phase? So being able to analyze the population that had COVID-19 during the assessment phase here of this strategy will really be contingent upon having the appropriate data within our population. So NLP, right now within Optum, we are focusing on how do we create those processes to mine the clinical notes data to help us fill some of that gap. And AI and machine learning, this is something that some EMRs have started to think about. How can we support any predictive modeling for both capacity and inpatient utilization, and looking forward there from a utilization perspective, but also about disease progression and the risk associated with certain populations. I think that would be incredibly beneficial to have as part of our assessment phase and our preparation and prevention, is a true and trained model to help us understand who is most likely for significant severe disease progression within the COVID-19 disease itself, but also for COVID patients and their other diseases, their comorbidities. So more to that end, really, as we move forward, and that'll be incredibly key to incorporate as well. Contact tracing, this is an item that really in the most recent days, as you know, Apple and Google have really partnered to invest in a contact tracing application and solution there. How can we use that in our mitigation and management phase to really be in a much different position the second time around? So testing and contact tracing, as those two come together to give us a clear picture of who are our infected patients and who has been exposed. That will allow provider organizations and others to really isolate the population that's been infected, allowing the rest of the population to feel, you know, safe, feel secure, feel that they are healthy and that they can continue on in certain areas of life that right now we had to completely shut down. So that'll be a really key piece of the equation also as that really comes to fruition. Therapeutics, I mentioned earlier that looking at some of those initial drugs and medication for hydroxychloroquine, chloroquine, remdesivir, interferon, they've been out there and there are several clinical studies still underway and publishing data in real time to help us understand you know, if those are really contributing positively to the outcome for COVID-19 populations. However, the data is so limited at this time, and it really is changing so frequently. So the conversation is going to continue there, of course, and as we have new drugs that are developed and approved to specifically target COVID-19, so they're not existing drugs that we are using to treat COVID-19, but maybe they're net new. Those will become part of the equation. And prioritizing populations, that's going to be a question once we actually have medications that are considered to be therapeutics and treatment options for COVID. How do we target which patients and populations maybe are receiving those initially as we think about really the ultimate availability of those and producing those for specific areas of the country and of the world. Reimbursement, this is one that we're all kind of feeling, I think, already, but is going to continue to be a question and really an area, a gray area for us to deal with. But how do we effectively code for patients with COVID-19? How did we maybe deal with that that time between December and April? And then how do we effectively ensure that moving forward, there's reimbursement for our providers in this new care delivery landscape around telemedicine, and what does the payment model kind of look like for that? And that is really changing, again, day by day, how we're responding to that, how regulatory organizations and CMS is responding to that. And finally, immunizations. This is a priority and top of mind for not only us in healthcare, but everyone in the world. And the timelines for that continue to be pretty far out, and continue to be, we need to be realistic. And the opportunity for the life sciences market to develop an immunization, test it, ensure that it is safe, and goes through the appropriate safety regulation testings before it actually can be manufactured and then distributed. It's a very long timeline. So once that actually becomes a reality, again, thinking about prioritization of immunizations for the high risk and at-risk populations is going to be, a question that from a provider standpoint, we're going to have to ask. And also, is that going to impact quality measurement? Will there be now a quality measure that we measure provider performance against for this vaccine? That's still, something we can consider in the long term. And in the last few minutes, as I think about some closing remarks and really how I wanted to wrap up the presentation today, of course, future surges are expected. So that's really where the cyclical visual comes into play. And I hope that a prevention, management, and assessment strategy in that cycle can really help the provider and payer and other organizations prepare for those future surges and really mitigate future risk while still providing quality of care to all of your populations. So not just the COVID-19 population, but all of your responsible patients. Enabling telemedicine, so telemedicine is going to be really critical for organizations to understand the opportunity today and then continue to evaluate efficacy and ability to scale the technology platforms to support telemedicine moving forward. So supporting the COVID-19 patients via telemedicine workflows, as well as the non-COVID, so your other chronic disease, as well as your worry well, as it's been called, populations, to balance that capacity demand that you might have had without telemedicine, while still reducing your exposure risk and ensuring you're effectively managing patients from home or from a lower setting of care. And predictive modeling, so looking forward, and retrospective impact analyses, looking backwards, will really give organizations that visibility to prepare for upcoming surges and future crises in the most effective way by using their own data and their own treatment outcomes to understand how to provide the best care to your populations and to those populations in need moving forward. So that was the presentation that I had pulled together today. I know that we do have about 10 minutes left, so I wanted to leave some time for questions, and I'm sure there are incredibly smart people on the phone that would love to share some of their opportunities or their work that they're doing. So if there's anyone that has anything to add, please feel free to jump in. Thank you.
Lucy, I have a question from one of the participants, and in your view, the question is on the data. How is the extrapolation or isolation process determined without grouping COPD, cancer, etc. patients who had comorbid primary diagnosis? It seems we're grouping a lung infection for a COPD patient into COVID-19 category.
So that's a great question, and I think that could maybe overlap with a few different use cases that I presented. So the way that, at least within Optum, the way that we're able to isolate different populations will be using claims and clinical data. So we do have really an integrated data set from our provider clients to help us isolate different condition evidence. So from a claims and clinical data source, you'd likely see ICD-10 coded evidence. So we capture that. For different conditions, there will be a set of diagnoses that our methodology teams define to be for COPD or hypertension or heart failure. And we really allow clients to also tweak those definitions. So beyond a standard set of diagnosis codes, clients can also create their own cohorts depending on if the coding at their organization is more specific and they want to focus on a subset of diagnosis codes, they can do that. Beyond ICD-10 codes, we also look to capture a bit of a broader net to capture patients that might have those conditions. So ICD-10 codes play one role, and then we also look at medication and assessment, so laboratory evidence, to help also indicate really where there's a high threshold of accuracy for the medication indicating that patient might be a diabetic or might have a certain condition. We've included that in our definition as well, or where ejection fraction or A1C might indicate the patient has a certain condition, we can capture that as well. But the flexibility of these cohorts is really what makes them, useful right now, because organizations can tweak those definitions. So not just using anything defined by Optum, but really what's most appropriate to them. And that also includes for the high-risk cohort that has been created and defined right now, because that was changing so often, not significantly, but there are additional factors that keep coming out with new evidence, or there's a lack of evidence that something should fall off the list. The flexibility of that cohort allows organizations to include or exclude certain factors that have been identified initially in that reporting. So if there's a specific diagnosis code that really is not specific enough to an organization and they would like to exclude that, they can do that within the reporting that's available from Optum. And there are other organizations out there right now that are using other platforms that I believe would be flexible as well, because just based on how quickly this crisis came to be and how quickly we are receiving new information about clinical trials and studies and ultimately who's in that high-risk bucket, we need to be able to be agile and pivot quickly to tweak those cohorts for intervention and for ultimately proactive outreach. Hopefully that answered the question.
Thank you. There was another participant who wanted to address the AI portion regarding COVID-19 triage.
Yeah, so I can speak at a high level. So within the AI space, there are so many incredible things that can be done, not just related to COVID-19, but so many in terms of supporting patients that maybe have mental health or behavioral health conditions, and that's expected to, progress as they do have a diagnosis for COVID-19. But I think what's been a primary need in the vein of AI is really starting to mine the underlying data that we do have to quickly identify trends and predict patients that will respond or not respond to certain treatment protocols, or also patients that are expected to have a decline in the other comorbidities that they might present with beyond COVID-19. And then, of course, the actual disease progression of COVID-19. So understanding patients that are beyond just that at-risk cohort of who are the patients that are expected to have a severe outcome if infected, but really getting crisp on who are the patients that, using almost a risk score or threshold, are expected to, have the outcome of mortality. How can we really understand and stratify that population so we know exactly where to focus our efforts and really where to prioritize that significant intervention? So within Optum, the AI capabilities are really initially the discussions are really starting to happen. It's a very complex space, and we're hoping to learn from those really innovative companies in the market right now. Even some of the EMR companies that are starting to think about how can we predict the likelihood of mortality and predict the riskiness of these patients, so that we can continue to provide that visibility and that stratification mechanism to our clients. But it is, I think, really an early conversation that we're hoping to dive into in more detail moving forward.
Lucy, my name is Joe Chapa. I can maybe give a little insight to what we've done. So our organization, Zebra Medical, is going to be putting out at no cost AI algorithm to look at lung burden or percentage of lung burden based on ground glass opacities. We have been in the trenches with the people at Northwell, and the feedback from the people at Northwell was, this is what we see. We have a whole floor, everyone's sick, everyone has a fever, everyone can't breathe, everyone's on how hopefully May 1st we'll be putting this out worldwide, only to the most severe organizations that have the highest population of COVID. So that's something to be looking forward to. And it was released 2 days ago at Northwell for them to use. But if you really think about it, the denser the ground glass is in the person's lungs, the less they can breathe. So unfortunately, it does use a CT. It's very exact science, but there's a lot of people looking at that to be able to go, okay, he or she needs to go here versus maybe you can wait. It's more for the major hospitals with big problems.
Thank you so much for sharing that. No, that's exactly right. And, you know, it is, as you mentioned, really an organization saying, this is my problem. This is what I'm up against. I have this entire floor and they're all sick. How can I understand why? And so as we think about broadening that to different lenses beyond lung function and maybe others to look at, you know, what are we seeing? What are the trends in my really sick populations? So I can mine that data and really figure out where the opportunities are. And as you mentioned, ultimately inform that triage process and the appropriate care setting to be managing those patients just in a more specific way. So it's like specialized medicine and taking what we can learn from the data we're collecting right now and partnering with those incredibly innovative companies to take that data and turn it into a really actionable insight.
Thank you. We have 2 minutes left. Any other questions? Nope. Okay, Lucy, thank you so much for your time, and for all the people on the phone that participated today. I want to thank you for everything.
Thank you all so much for your time. Thank you, Tanya, for coordinating and organizing, and please feel free to reach out directly to me at any point, lucyparenti@optum.com. I really look forward to talking to everyone, and thank you again. Have a great rest of your week.
Thank you.